Now the next topic, beta. Next topic is dysphonia plica ventricularis. Dysphonia plica ventricularis. It is also known as ventricular dysphonia. So here the voice is produced by the false vocal cord. Very important. Dysphonia plica ventricularis is a condition in which the voice is produced by the false vocal cord. And what is the quality of the voice? The quality of voice, it is rough, low pitched voice, and it is a unpleasant voice. What are the causes? What is the etiology? The etiology of dysphonia plica ventricularis, it can be functional, that is, it is psychogenic. Here the larynx is totally normal. So in functional causes, in functional case, the reason is psychogenic and the larynx is totally normal. Then the next cause is organic. Organic means that there has to be some cause to it. Now what is the cause in organic? The true vocal cord, in this case they are impaired either by the paralysis. Either by the paralysis means that there can be paralysis of the recurrent laryngeal nerve, the superior laryngeal nerve, or combined vagal nerve paralysis. So paralysis, or if the true vocal cord is fixed, means the nerve is normal, there can be either tumor or any kind of obstruction which is causing the fixation of the true vocal cord. So the function of the true vocal cord, that is the phonation, is taken over by the false vocal cord. So second cause is the fixation of the true vocal cord. The third is when we are doing any surgical excision, means if we are doing a T1 or T2 lesion, early lesion of the true vocal cord, CA larynx. So if we excise that, so if after excision the true vocal cord mobility can be impaired. So any kind of surgical excision can also be the reason or the organic cause of the dysphonia plica ventricularis. Or the fourth cause can be when the tumor and the false cord, they try to compensate the function of the true cord. So on indirect laryngoscopy, what we will see? The indirect laryngoscopy will show us that the false cord, they approximate partially or completely, and they obscure the view of the true vocal cord. Meaning when we are telling the patient to phonate, either we are doing a flexible laryngoscopy, or if we are doing a indirect laryngoscopy with the help of laryngeal mirror, when we tell the patient to phonate, the false vocal cord, they come and meet before the true vocal cord. We are unable to see the view of the true vocal cord. Now the next topic is functional aphonia. The functional aphonia is also known as habitual dysphonia or the historical aphonia. The reason of this is in the name. It is functional, means there is no organic cause to it, and there is a hysterical, means when the patient is in hysteria. So what is functional aphonia? Functional aphonia is mostly seen in emotionally labile females. It is seen in emotionally labile females in the age group of 15 to 30 years. Very important. Emotionally labile females in the age group of 15 to 30 years. Remember, puberphonia is seen in emotionally labile males. So they are seen at the puberty. But functional aphonia is seen in emotionally labile females in the age group of 15 to 30 years. So aphonia, that is sudden loss of voice, basically the aphonia is sudden in onset. So it is usually sudden in onset, and as I said, it is the larynx here is normal. So it is unaccompanied by any of the laryngeal symptoms. So it is unaccompanied by any laryngeal symptoms. So in dysphonia also we have seen that there is a psychogenic cause. In functional aphonia, it is totally a psychological condition in which the larynx will be normal, so there will be no laryngeal symptoms. Only thing is that the patient will not be speaking. She will present to you in the OPD, and the attendants will tell you that the patient has sudden aphonia. So the patient in the OPD, she communicates to us with whisper. My name is Sonali. So the patient will only whisper. The patient will not be able to speak properly. So even though the patient is aphonic, when you tell the patient suddenly, when you're doing the examination and you're talking to the patient, and you suddenly tell the patient, okay beta, you cough. So when the patient cough, the sound of the cough is good. So 2 stars to it. How will you diagnose without any examination that the patient is having a functional aphonia? First of all, the patient will be a female in the age group of 15 to 30 years. The attendants will tell you that she has sudden onset aphonia. Now she will be communicating with you only by whisper. And when you tell the patient to cough, the sound of the cough is good. And when you do indirect laryngoscopy, you will not find any laryngeal paralysis. So on examination in indirect laryngoscopy, the vocal cord will be in abducted position and they fails to adduct. The vocal cord, they fail to adduct in the phonation. So patient will the vocal cords, they will fail to adduct on phonation, but when the patient during the examination indirect laryngoscopy, when you tell the patient to cough, so when the patient is coughing, at that time there will be adduction. So that will indicate that the adductor function of the larynx is preserved, and it will indicate that there is a normal adductor function. Now, what is the treatment of such patient? As I said, that this is a totally psychological condition. So patient needs psychotherapy. So the role of psychiatrist is of paramount importance as compared to ENT specialist. The patient will, this is a totally psychotherapy, patient will need psychotherapy because this has, the etiology is totally psychological and speech therapy has no role in it. Now coming to the next condition, a very important condition, that is known as phonesthenia. So write down beta, phonesthenia. It is the weakness of voice. It is the weakness of voice due to fatigueness of phonatory muscles. By phonatory muscles, I mean the muscles which are involved in the phonation. So it is the weakness of the voice due to fatigueness of the phonatory muscle, and it is usually seen, the etiology is that it is usually seen when we are abusing or misusing our voice, or it can also follow laryngitis. So etiology is either abuse or misuse of the voice, or following a laryngitis we will see a condition which is the weakness of voice due to fatigueness of the phonatory muscle. Now, what is the patient, how the patient will present to you in the OPD? The patient will complain that he or she has the fatigability of the voice. So the patient will not be able to speak continuously for a good period of time. So patient will have fatigability of the voice. Now, indirect laryngoscopy in phonesthenia, you will have these 3 conditions, in which first of all, the image 1, you will see a elliptical space. Number 2, you will see a triangular space which is there only in the posterior commissure, and there is a third condition in which there will be involvement of both the thyroarytenoid and the interarytenoid muscle. So it will be like a inverted key. This is the keyhole. So it will be like a inverted keyhole appearance. So this is, here there is an involvement of both. So condition A and B are seen in together, they are seen in condition C. So there is involvement of the thyroarytenoid muscle and the interarytenoid muscle. So phonesthesia, elliptical, write down beta. The elliptical space between the cords is seen in the weakness of thyroarytenoid muscle, whereas the triangular space, like here, the triangular space in the posterior commissure, this space in the posterior commissure, it is because of the weakness of the interarytenoid muscle. And when there is a keyhole appearance, inverted keyhole appearance of glottis, in when both the thyroarytenoid and interarytenoid muscles are involved, like in the condition C, like in this, you will have a inverted keyhole appearance. Now, what is the treatment of phonesthenia? The treatment is voice rest and maintaining the vocal hygiene. Remember, if you have any cause, that will be the treatment of the condition. So in this condition, the cause was that the patient was having a was abusing or misusing the voice. So you tell the patient to do voice rest and to maintain the vocal hygiene, and they should be emphasized on the periods of voice rest after excessive use of voice. So that will result in the improvement of this condition, that is phonosthenia. Now coming to the next condition, that is the spasmodic dysphonia. It is also known as the laryngeal dystonia. Now what are they? They are the focal laryngeal dystonia. They are the focal laryngeal dystonia in which spasmodic contraction of the intrinsic laryngeal musculature occurs. So intrinsic musculature, by intrinsic musculature I mean the adductor muscle and the abductor muscle. So it is basically like a tick on the face when we see. So in the ticks there will be a spasm of certain group of muscles. So similarly in the larynx also, the spasmodic dysphonia condition, which is also known as laryngeal dystonia. So there will be a focal laryngeal dystonia in which spasmodic contraction of muscles, intrinsic musculature occurs, which are involved in the abduction and the adduction of the two vocal cords. So they are basically classified into a adductor type or a abductor type. So remember, the most common is the adductor type of dysphonia. So it is the most common is the adductor type of dysphonia. Now what will be the characteristic of adductor spasmodic dysphonia? Now here the patient, the two vocal cords of the patient, they will be adducted. So this is abduction and this is adduction. So in case of adduction, they will be totally, the vocal cords will be like this, they will be adducted. So the voice of the patient will be harsh, it will be strained, and it will be a strangled quality of voice with the voice breaks. So if you see the adductor spasmodic dysphonia, the patient voice will be a strained and strangulated quality. Like if you ask the patient his name, so the patient will tell you, my name is Harsh. So imagine this is the patient whose voice I just now imitated. So the voice is harsh, it is strained, and it is strangulated quality. Now similarly, if you see the abductor spasmodic dysphonia, in abductor spasmodic dysphonia, the dysphonia of the abductor musculature, it occurs, and the voice will be characteristically, it will be sustained breathiness of the voice, and the quality of voice will be whispering, as if the patient is whispering, and the with the breathing voice breaks. So the voice will be breathy in case of abductor spasmodic dysphonia. So when you tell the ask the patient what is the patient's name, so the patient will tell you in a breathy voice or the whispering quality, my name is Harsh. So that is how, this is the characteristic of the abductor dysphonia. Now what is the treatment of choice in which in case of spasmodic dysphonia? The treatment of choice is that we under electromyography we inject botulinum toxin into these muscles. So in treatment of choice is botulinum injection, and it is not only a single injection which will help. There will be a series, multiple injections of may be required, so that we can correct this spasmodic dysphonia. Now coming to the next condition, that is known as the puberphonia. Remember, puberphonia, there is also alternative name. It is also called as, write down beta, it is also called as mutational falsetto voice. So puberphonia has other name also. It is also known as mutational falsetto voice, and it is typically seen in males. So it is seen in males. If you remember functional aphonia, which we have discussed just now, the functional aphonia is seen typically in emotionally labile females who are there in the age group of 15 to 30 years. So puberphonia is seen in the males at the time of puberty. So it is seen in males at the time of puberty. So what happens in the at puberty in the voice is that their sharp pitch voice, the voice which is sharp pitch, it becomes low pitch because of the growth of the sudden growth in the larynx size. So the vocal cords which were stretched, they become relaxed. So that means the voice which will now be produced after during puberty will be a low pitched voice. But if this fails to occur, that is, if there is a persistent of high pitched voice at the puberty or after the puberty, this will lead to the high pitched voice after the puberty also. So this condition is known as the puberphonia, that is also known as mutational falsetto voice. So write down beta, it is the failure, it is the failure of changing of the voice from high pitch to low pitch in males. That is, it can also be said that it is the persistent of childhood high pitched voice. This condition is known as the puberphonia, and it is typically seen in boys. As I said, the functional aphonia is seen in females. So this condition, that is puberphonia, it is typically seen in boys who are emotionally insecure, and they show excessive attachment to their mothers. So they show excessive attachment to their mothers, but the main condition is that along with this puberphonia, the rest of the development, the overall development, be it physical or sexual development, this is normal. So only their voice will remain as in the childhood, like it will be a high pitched voice after puberty, but the rest of the growth of the body, like the physical and the sexual matureness, it will be normal. Now coming to the management of puberphonia, in management there is a particular test which is done clinically, that is known as the Gutzman pressure test. This is very important and often it has been asked in the examination. Now what is Gutzman pressure test? It is the production of low pitch voice on pressing the thyroid prominence backwards and downwards. So when you in a clinic, when you press the thyroid prominence of the patient or the Adam's apple of the patient, this is the Adam's apple, and if you press this downwards and backwards, and if in the boy there is a production of low pitch voice, that means that this patient is having a puberphonia and they should be treated with type 3 thyroplasty. Now, as you are aware that the Ishiki has described in 1972 various type of thyroplasty. Type 1 thyroplasty is medialization of the vocal cords. Type 2 is lateralization of the vocal cords. Type 3 is shortening of the vocal cords, and type 4 is the lengthening of the vocal cords. So, in a puberphonia case, we will be doing a type 3 thyroplasty, that is, we are doing a surgical shortening or loosening of the true vocal cord. Now, the next condition is androphonia. Basically, what is androphonia? It is the presence of low pitch voice in female, that is a masculine voice or a male voice in female. So, what is the treatment of this? Treatment of this is type 4 thyroplasty. And what is type 4 thyroplasty? It is the surgical lengthening or tightening of the vocal cord. Suppose if I have, imagine guitar string. So when you stretch the guitar string, you are doing the lengthening, you are doing the tightening of that string. So when you strengthen, you touch it, you will get a high pitched note. So similarly in androphonia also we are doing the same thing. We are lengthening or tightening the vocal cord. This is known as the type 4 thyroplasty. So always remember, in a puberphonia case, we are doing a type 3 thyroplasty, whereas in a androphonia case, we will be doing a type 4 thyroplasty. Now coming to next condition, which is also a speech related condition, that is known as a mogiphonia. Now what is mogiphonia? It is a speech related problem in public places only. The patient will suddenly call on a stage to deliver a speech. The patient's muscles, they will go into a spasm. The patient will not be able to speak. So it is a psychological condition. So this speech problem in a public place, basically this is a psychological condition, and the treatment of such patient will be that the patient need a psychotherapy. So remember androphonia and mogiphonia. Androphonia is a production of low pitch voice in female, that is a masculine voice in female, and mogiphonia is a psychological condition. It is a speech problem in the public places.